Okay. So my quick didactic, thanks Rachel, is which is better for baby, methadone, buprenorphine, or buprenorphine plus naloxone, and there we go. And so one of the things that we're obviously thinking about whenever we're talking about this subject is neonatal abstinence syndrome, NAS, or what we're now a more clinically descriptive title that's being used is neonatal opioid withdrawal syndrome, NOWS. And so I won't spend too much time on this chart because I think we are quite familiar with this, but the rate of NAS is increasing over the past decades. It is costing hospitals a lot. It is costing families a lot emotionally. This refers to the behavioral dysregulation that occurs within a couple of days for infants that are chronically exposed to opioids. And let's see. And so this graph, I'm just going over kind of what's the I should have cut off the bottom of the graph whenever I did this. But this graph kind of shows the difference in different types of opioids in relationship to the onset of NAS, the frequency, and then the duration. And what this shows us is that shorter acting opioids, not particularly surprisingly, have a decreased time to onset for infants experiencing opioid withdrawal symptoms. They also have a decreased duration. And then we see the longer acting opioids, prescription opioid medications, methadone, buprenorphine, have a longer onset to infant experiencing symptoms, 2, even 3 or more days before an infant might experience the symptoms, and then a longer duration as well. And then there's something that's mentioned at the bottom, which I want to talk about here. So I'm going to go to this. So other factors that contribute to opioid withdrawal syndrome in the newborn, genetics is a very big one, genetic or epigenetic factors. And we know this association quite well, although the mechanisms might not be entirely understood. But it's very true that methadone and buprenorphine dose is not consistently related to opioid withdrawal symptom severity. And so it is, I have women who are on a very low dose, like 2 or 4 milligrams of buprenorphine throughout the duration of their pregnancy, and they will have a baby that has either moderate or severe NAS and has to be in the hospital for a week or 2. And I have also had women who have been on the higher dose or the max dose of buprenorphine, and they're on their 3rd child, and they haven't had one baby who's experienced opioid withdrawal with any of their deliveries. Other things that that we see that contribute, so other substances or drugs, so SSRIs, benzodiazepines, and tobacco use. And so for women who have to remain on MAT or opioid maintenance medications throughout the duration of their pregnancy, I kind of find the tobacco uses to be a helpful tool that we can work on, because maybe they can't, there's not a negotiation over whether or not they need their methadone or their buprenorphine, but working with a woman to cut down on a couple of cigarettes per week is something that they really can work towards and might have a very meaningful difference. Birth weight and gestational age are likewise related to NAS. Babies that are older in gestational age, and with that usually comes a greater birth weight, have more developed nervous systems and are better at handling opioid withdrawal syndrome. And then the other, the last point that's on here is hospital protocols. So the assessment tool that different hospitals might use to screen for NAS in the newborn. Sometimes you might have 2 or 3 shift changes, and so you'll have someone doing the first screen and then someone else doing a different screen. They can be subjective in that way. And then the last 3, not breastfeeding, separating mother and baby, and rooming in or skin-to-skin contact, those kind of all go together. We know that breastfeeding for women who would like to is something that can be helpful with the severity of NAS. And so hospitals that allow for rooming and allow for mom and baby to be together and for a lot of skin-to-skin contact is really helpful. And one more slide before I move on to the medication part of this. Something that's a little bit newer, but it's called Eat, Sleep, and Console. It is an approach used to sort of focus on the comfort and care of infants and maximize the use of opioids that are needed to treat NAS. And the idea is that if an infant is eating, if they're sleeping, if they're able to be consoled in a short amount of time, that they're basically doing fairly well. And so this is just kind of a sample screening chart of what a hospital might use if they're using Eat, Sleep, and Console. In terms of opioid maintenance medications that we're about to cover, there's methadone, buprenorphine monotherapy, and then combination product, buprenorphine plus naloxone. The advantages of methadone and buprenorphine, they both reduce cravings, block effects of other opioids, they prevent the withdrawal onset. Buprenorphine has some advantages of a lower risk of overdose, fewer drug-to-drug interactions, and a shorter course of NAS. In terms of the disadvantages, it can take some time for methadone, it can take some time to reach the stable dose. There is the increased risk of overdose, and it can often require daily visits to federally qualified programs, which can be pretty demanding on some folks. And then there is a longer NAS duration and more medication that's used to treat NAS, and we'll go over that in the next slide. Buprenorphine, you can precipitate clinical withdrawal if you start buprenorphine and a woman still has opioids in her system, and then the possible increased risk of diversion. About a decade ago, there was a study called the Mother study that compared buprenorphine-exposed neonates to methadone-exposed neonates, and importantly, both medications in the context of comprehensive care produced similar maternal treatment and delivery outcomes. And what really made buprenorphine stand out is that about neonates exposed to buprenorphine as opposed to methadone required almost 90% less morphine to treat their opioid withdrawal syndrome. They spent about 40% less time in the hospital, and they spent about 60% less time in the hospital being treated for NAS. And this next study is a meta-analysis that again affirms what most of us probably already know, in that buprenorphine-exposed neonates compared to methadone have a higher mean gestational age, a greater birth weight, greater length, greater head circumference, and again showed that NAS duration was shorter and the total morphine dose used was also lower. And so now we get to comparing combination product, buprenorphine plus naloxone, versus buprenorphine or methadone. And this is what you'll see is both of these studies that I link at the bottom, and these are not the only ones out there. There's actually growing knowledge, but these were done some time ago. So these were done in 2013 and 2015. This isn't necessarily that new. And so whenever they looked at the collective data that compared combination product to methadone, it showed similar maternal outcomes as those seen with buprenorphine alone, and a similar reduction in NAS severity. Whenever the collective data that compared combination product to buprenorphine alone showed similar maternal outcomes and similar birth outcomes, including NAS severity. And so nationally, it is more common to see buprenorphine monotherapy prescribed for pregnant women, although I think with this increasing evidence, there are more and more institutions and providers that are prescribing combination product, Suboxone, with confidence in the pregnant population. And so the very last slide, I just wanted to touch on breastfeeding. So for women who are on buprenorphine and methadone, it is recommended, or breastfeeding is compatible and recommended with these medications. there is no data on Suboxone. The oral absorption of naloxone is likely very minimal, but we just don't have the data yet. And so we should really be exercising caution in administering Suboxone or combination product to a nursing woman. And just like we would for any maintenance medication that we're prescribing in breastfeeding women, we would advise mom to make sure that other doctors that she's seen are aware of this, especially pediatrician, and monitor baby for drowsiness, wakefulness, breathing difficulties. And that's it, guys.
Thank you, Dr. Boyars. Before we move to questions and a discussion with Dr. Boyars, I just wanted to give a shout out to other telementoring programs in our state. We have Project ECHO Opioid Use Disorders run out of MUSC by Dr. Karen Hartwell. I'm the coordinator of that ECHO, so if you are interested in that, you can reach out to me. We also have an excellent telementoring program run by Dr. Divya Ahuja out of USC on viral hepatitis. So the information for how to reach out to his team is also located here.